Let's talk COVID. There are so many misconceptions with COVID, but today we have a special guest, Dr. Anirudh Penukonda, a pulmonologist with Baylor Hospital Systems. Stay tuned for an excellent podcast. All right. Thank you, Charlene family, for tuning in. We have a special guest today, Dr. Anirudh Penukonda. He is a pulmonologist and critical care doctor at Baylor Irving and a good friend of mine. So thank you so much, Dr. Anirudh, for taking your time, really, and just touching base on what you do and how you help patients and families throughout the Metroplex.
Great to be here, Charles. Thanks for having me.
Thank you so much. So what we wanted to touch base on today, there's so many things that's happening in the world, but we wanted to kind of touch base on what pulmonology is and then break that down and then talk a little bit about COVID. So Dr. Anirudh, could you walk me through what pulmonology is and what it is that you do to help patients with those common diseases?
Sure. So pulmonology is a specialty within internal medicine that focuses on lung diseases that can range anywhere from congenital lung diseases to much more common things such as asthma or chronic obstructive pulmonary disease, which is related to smoking. We also see rarer lung diseases such as those that scar the lungs, amongst many other lung diseases. We basically are interested in how people are breathing and how it affects their daily lives and how to improve that aspect of their life.
That's awesome. What do you see more common? Like, what are some of the common diseases that you see on a day-to-day basis in pulmonology?
So I think before the COVID pandemic, we saw a lot of chronic obstructive pulmonary disease, which is primarily caused by smoking. We also, depending on the season, saw severe cases of acute respiratory distress syndrome, which can be caused by pneumonia, common bacterial infections of the lung, or influenza, which can all kind of lead to the same severe lung disease that puts people in the ICU on ventilators. So those are some of the things that we treat often as pulmonologists and ICU doctors.
Okay. So before it gets to the point where it's critical, what are some things that pulmonologists do to help patients through their disease process?
So it depends on what kind of disease we're looking at. If we're looking at COPD or asthma, we're interested in first trying to get people away from the exposures that are causing the disease, whether it's smoking or environmental allergens, common things in the home environment that can trigger flare-ups of lung disease, such as mold, pests, roaches, things in the environment that can flare up their airways. And then we're trying to, take a detailed history from the patient to figure these things out. And then once we have an idea, we do testing to see how their pulmonary function is, and that's doing a series of breathing tests where we can quantify exactly what kind of lung disease they have, how their breathing and airways work, and then that'll help us kind of reach a decision of how to treat them best, whether it's with inhalers, whether we need to do further tests such as checking their sputum for infection to see if there's anything that needs treatment against an infectious disease that's causing their underlying lung disease. So there's kind of a variety of different things that we can do, but it all starts with taking a history and doing some investigations and doing a good clinical exam of the patient.
Oh, that's amazing. And when you mentioned, it's almost like kind of taking a look at the patient's environment and seeing some triggers that are actually causing those flare-ups. And that's kind of neat. Like you said, pests and even rodents, so it's amazing that those things can actually affect a whole bunch of things, one of the things that that everyone's experiencing right now is COVID, and I know with you being a pulmonologist and a critical care doctor in the ICU, you see the end of it, right? The tough parts where they're on ventilators, but you know, early signs and symptoms. Let's walk through what are some early signs and symptoms before that occurs. If you could help us kind of understand that, that would be great.
Sure. I think one of the difficult things about COVID is that it can present as a common viral illness with just very common symptoms such as fevers, chills, muscle aches, fatigue, which have occurred with other viral illnesses such as the flu. The things that might be a little more particular to COVID that we've seen is the loss of smell and taste, or changes in smell and taste. We've seen some instances of confusion, which can also reflect that COVID is invasive to the central nervous system. Sometimes abdominal symptoms are pretty common, such as nausea, vomiting, or diarrhea. So those are sometimes early signs of COVID infection. Now, usually about a week and sometimes less is when you start to see the development of more respiratory symptoms, including cough, shortness of breath, and sometimes chest pain. The cough is usually a dry one, although we've had plenty of patients who do produce sputum. You can have infections that come with the COVID infection, such as a bacterial pneumonia, which kind of rides on the coattails of COVID and can cause a lot of even higher fevers and a lot of kind of thick, nasty sputum. The chest pain in COVID tends to be when the patient is taking a deep breath, what we call pleurisy. But oftentimes, if they have another event that comes with their COVID infection, such as a blood clot in their lungs or a heart attack, the chest pain can be different in character.
Wow. And it's amazing because there's so many symptoms of COVID. And I feel like one of the things that a lot of even our patients, when they have those small symptoms, or with symptoms that are constantly lingering, if you delay to go to the hospital and actually get worse, correct?
Yes, one of the things that is kind of unique about COVID, and it might be just that we've seen so much COVID in any hospital. They've had much more experience on a sheer number basis compared to the influenza in any given year, is that the development of symptoms happens almost, fairly predictably. That, we have these symptoms that we talk about: fever, chill, muscle aches, diarrhea, and then you have the development of breathing symptoms. So depending on where or when the patient comes into the hospital, really determines how much we can do for the patient and at what point we can intervene in the disease course. So by the time I get called in the hospital as a pulmonologist, it can be anywhere from in the emergency room, or it can be on the hospital floor, or in the ICU. And it really depends on when the patient presents to the hospital.
That's good. I think a lot of times, as life goes on and things happen, I feel like, I appreciate you kind of sharing your experiences with us, because it helps everyone to understand what actually happens as COVID progresses. And so if you can you walk us through maybe like a case where you see a patient that's actually is actually getting worse and worse, just for the transparency, can you walk us through that, for maybe just kind of helping the audience understand that?
Sure. I think what we've seen most commonly is that a patient would come to the hospital when they start feeling short of breath, to the point that they can't carry on their normal activities at home, or if they haven't been able to eat or keep down food and they feel just so fatigued that they're unable to do basic things. And by that time, when they come to the ER with that kind of symptom pattern, they're usually low on their blood oxygen saturation, meaning the amount of oxygen is low when they're either checked in the bloodstream or with a pulse oximeter on their finger. And at that time, we are able to get X-rays and do some laboratories to check if there's an excess amount of inflammation going on in their body, and to see if their X-ray fits the pattern of a COVID infection. Usually on an X-ray for COVID, we see kind of what we call infiltrates on both sides of the lungs, kind of at the outsides of the lungs, that reflects infection and inflammation, and maybe even blood clots, small blood clots in the outsides of the lungs. So from that point on, we can decide where the patient needs to go, if they need to go to a normal hospital floor, or if they're requiring a really higher level of oxygen support, they probably need to go to the intensive care unit. And if they're absolutely failing from a breathing standpoint, if they're confused or their oxygen is not responding to normal oxygen therapies that we deliver with a tube in their nose, then we have to make the decision to put them on a ventilator. So we've seen patients progress through the steps of needing oxygen in their nose to a higher level of oxygen, such as with a face mask, to a ventilator, all within hours. Wow. Sometimes. And oftentimes it takes a couple of days to go through that progression, but really it depends on the patient's, comorbid conditions. If they came in with a lot of underlying medical problems, or if they are healthy and have a lot of reserve, they might be able to last longer on the lower amounts of oxygen. So
wow. And then after they receive that type of treatment, what's the kind of like the course, even getting out of the hospital? How does that look like? I know every patient is different, but what does that look like to some patients?
Sure. I think we can probably start with a best case scenario, which is a patient comes into the ER, they are found to have a COVID infection, they're requiring a few liters of oxygen support. We're able to start antiviral medications, we're able to start steroids, and we're able to monitor them on the floor and not in the ICU. This patient should start to feel better within a day or two, should be able to take food and water on their own, and will slowly get the energy back to, start to sit up in bed and maybe even walk around the room. And if all that progresses well in 2 to 3 days, they can be assessed to see if they need extra oxygen for home. Usually the antiviral course is for 5 days, but if the patient improves faster than that, we can get them discharged from the hospital faster than that. So that's a best case scenario for a hospitalized COVID patient. Now, unfortunately, what we see a lot is that the patient has the progression of increasing oxygen requirements and failing respiratory requirements, and also other organ dysfunctions, such as their kidneys in the setting of a lot of inflammation, and failing breathing will take a hit. Their kidneys will start to malfunction, they'll become confused, and all this will end up often with the patient on the ventilator in the ICU. And once the patient is in that severe situation of a severe COVID infection requiring a mechanical ventilator to do the work of breathing for them, we're often looking at 1 to 2 to 3 weeks, and a few times more than that before they can even be taken off of the ventilator. And that again is once they're that severely ill, the chances of a bad outcome, including death, go up higher.
Wow. And it's so important because I think a lot of times as if you're not in that situation or you're not around that, then COVID just seems like it's, like another disease. But I think a lot of times the awareness of how it can become worse is very important for everyone to understand. And I think also we talked about this a little bit earlier. Prevention is so huge. And what are some ways that, I know a lot of people talk about PPE, and what are some ways that you would recommend, Dr. Anirudh, for just prevention for spreading of COVID and also just, getting infected as well with COVID?
Sure. I think I'll start by sharing something from the hospital. One of the things that I think a lot of hospitals have realized is that healthcare workers, by and large, have been infected with COVID, not from patients, but more so from interactions between themselves or from the home setting. So that tells you that adequate PPE, which anyone in the hospital is following the guidelines. We're wearing full face masks, face shields, gloves, gowns. If a patient is coughing, or if we're doing procedures where we can expect COVID to be put into the air or aerosolized, we're wearing N95 masks for an increased layer of protection. So in that setting, we're pretty well protected from contracting the virus. So it's really in the settings that we're not wearing those, whether it's in break rooms where, workers are sharing lunches or snacks when their guard is let down. And that same scenario goes into the household and out of work, whether it's at restaurants or bars where their guard is let down, that the COVID virus has an opportunity to spread. So, to extrapolate from that, to really prevent and be cautious in the home setting and outside of work, to wear masks when you're around other people and in public settings, to practice social distancing, to practice good hand hygiene, really be extra cognizant about high-risk settings such as crowded spaces where distancing is not going to be possible, or situations where you're in prolonged contact, because it's not just the contact, it's the duration that you're in contact with another person who could be infected that may make the difference whether you get infected yourself.
Yeah, that's good. And especially as we're coming up on Thanksgiving and Christmas, holidays and people gathering, it's I think it's so important to make sure that we abide by these precautions, because when we're protecting ourselves, we're protecting other people too. Holidays are tough. What would you recommend, as well as people are even maybe trying to gather, or what would you say is the best advice for that?
Yeah, I think it's really tough. There's just at this point of the pandemic when so much family has been apart, and there's a real desire for people to get together and see each other once again. I'll say it's much harder to backtrack to figure out where anyone or yourself was infected by COVID, because oftentimes we know that if there's an infected person within a household, that the spread of COVID within that household is very rapid, to where it can't be traced back. So in light of that, to really try and wear masks whenever you're in contact with family members, even that you're not normally in contact with, who travel in different circles in their own daily lives, when if you intersect with them in a gathering that you're not able to avoid, to really, I guess, don't think too hard about putting your mask on, because people will understand that it's really in everyone's best interest to prevent the spread, even though any individual might not suffer severe consequences. It's really the individuals who are at highest risk are being affected by high levels of COVID around them. And the only way to prevent that in a family or friend circle is to really try to mask up and practice social distancing if it's unavoidable to gather. So.
Oh, that's good. That's good. As we come to a close, any closing thoughts that you could just offer to the audience regarding COVID and just regarding pulmonology in general?
Sure. I think one of the things at this point of the pandemic we're seeing that I'm surprised about is we've seen a number of young people who had COVID 2 or 3 months ago completely resolve their infections, and they're coming back with new illnesses such as heart failure, where their heart function is not normal, and they're unable to meet the demands of everyday activities because their heart is not pumping normally. That's one thing we've seen. We've seen blood clots form. Some of them have been almost fatal. They usually form in the legs, and they can sometimes travel into the lungs. This is called a pulmonary embolism. We've seen that develop after COVID infections. There is a number of people who have persistent symptoms who came into their COVID infection without any prior medical problems, and they're not able to completely get back to normal even months after the infection, which I guess goes to drive home the point that even if you're young and in great health, it doesn't buy you immunity from long-term consequences and some potentially serious consequences of the infection. And we're only just starting to see those as we get further away from the start of the pandemic.
Yeah,
Oh,
that's good. I appreciate it. I think, it's so important, and I appreciate you taking the time to do this podcast, because I feel like in this season, as things are changing and the pandemics and cases are increasing, it's so important that everyone continues to maintain social distancing, continues to wear PPE, and not only to protect yourself, but also protect your loved ones and those around you. And so, Dr. Anirudh, thank you so much for taking the time and just sharing some great knowledge. And I know you experience a lot of cases in the hospital, and it means a lot that you could share just some good knowledge for us today.
Sure, Charles. And if I could put in two plugs, just if you do have symptoms of COVID, to try and come in when you are feeling short of breath, and not to wait at home, because the earlier you come into the hospital, the more effective our treatments can be. And then the other thing is, if you have other symptoms such as debilitating chest pain or new weakness or anything that could be a stroke or a heart attack or any severe medical condition, not to wait too long to come into the hospital, to really take care of yourself, because the hospital is still the safest place to be to treat these conditions rather than wait at home.
Awesome. Thank you so much. Have a good one. Thank you, Charlotte family, for tuning in. And I hope this was a blessing to you and to your family and patients in the Metroplex. Have a good one.
Thank you, Charles.
Thanks for listening to Healthcare That Cares. For more information about Charlin, visit charlin.org. That's CHARLIN.org. And follow us on social media: Facebook, Twitter, LinkedIn, Instagram. Our handle is Charlin Health Services. God bless and see you next time.